Okay, hello and welcome to the Internal Medicine series for clinical clerkships. Today we'll be discussing GI disorders, a very important topic specifically relating to the types of colitis and also how to differentiate between the different types of colitis. So what we're going to be doing is I'm going to be giving a brief overview of the different types of colitis, how we can break it down by differential, okay? And also we're going to be taking a very structured approach in terms of how to differentiate one type of colitis from the others. So just an overview, a colitis, okay, is defined as an inflammation of the coli. So the coli is not only referring to the colon, but also some of the small intestines as well. So taking a very structured approach, in medical school we learned this acronym Vindicate, right? And this helps us remember all the different types of systems in terms of when we're considering a broad differential diagnosis. So the ones that really are relevant in terms of talking about colitis include vascular, infectious, inflammatory, idiopathic, and also autoimmune. And we see that right here. So infectious translates to infectious, okay? Immune mediated is autoimmune, ischemic is vascular related, and also idiopathic is, well, idiopathic. So in terms of the different types of colitis, I've broken it down by the 4 types that we've just mentioned. So under infectious, we're really thinking about things like infectious diarrhea, right? And this includes things like viral enteritis or colitis, bacterial, and also C. diff, which we're really talking about on its own subtype right here. The second class is immune-mediated. So under here, the most common types include Crohn's disease and also ulcerative colitis. In terms of ischemic colitis, well, there's just one ischemic colitis, and also idiopathic, there's microscopic colitis, which is actually a class including a class of 2 types of microscopic colitis, including the lymphocytic colitis and also the collagenous colitis. This is a very rare group. So let's begin by talking about infectious colitis, including the viral, bacterial, and also C. diff. So this is just a very broad structure that we're taking here. It's called the DTRAD, right? So this is really a structured approach to help us think about some of the things relating to the different types of colitis that can be used to distinguish one type from another. So in terms of the demographics, we're really thinking that anyone here can be affected by infectious colitis, okay? However, the literature suggests that those who are 65 and older and also neonates who are younger than 3 months are most likely and most prone to having infectious colitis. And I guess if we think about it from a pathophysiological standpoint, there's a good reason for that. Those are the 2 populations that are very likely to be immunocompromised. So when you have an external pathogen going into the body, into the GI tract, it's very likely that, or I guess it's more likely in those populations that they will have an infectious colitis, a persistence of this organism causing problems in the body. And in terms of the timing, this is actually very important. The timing is really one of the hallmarks that will allow you to distinguish infectious colitis from the other types. So the timing is that this will take about 2 to 12 days total for the infectious colitis to run its course. Okay, it's acute onset and also a very rapid return to the normal state, and this is really the hallmark. So it's a rapid onset and also rapid return to normal state. In terms of the risk factors, let's break this down by whether we're talking about viral and bacterial versus C. diff. So if we're talking about viral and bacterial, the things that would be considered risk factors are immunocompromised state, okay, household infection, also ingestion of raw or undercooked, uncooked foods. So that's really the risk factors for viral and bacterial. However, for C. diff, you can have some of those similar factors overlap, but the more classic ones include antibiotic use recently, chronic proton pump inhibitor use, okay, which increases the pH in the colon, and also recent or prolonged hospitalization. All right, and in terms of the associated symptoms, the only hallmark here is vomiting. Okay, so you are unlikely to get vomiting in the other 3 types of colitis that I've mentioned. Other associated symptoms would include fevers and chills, loss of appetite, and dehydration, but those are really more nonspecific. Really, the hallmark here is vomiting. This is one that you're very likely to get in infectious colitis. That's very rare in the other ones. Okay, so you'll really be able to distinguish infectious colitis from the other types based on timing and associated symptoms. Okay, the diagnosis is really based on a stool toxin assay and also stool culture. Okay, a biopsy plays a very minimal role in classifying and also diagnosing infectious colitis. So now we're off to the next type, the second type of colitis, and this is an immune-mediated colitis, or the autoimmune colitis, right? And the two major groups we're going to talk about include Crohn's and ulcerative colitis. So it's not too hard to imagine that if we're talking about an autoimmune state here, right, the demographics will likely be, if we're to generalize, young females of reproductive age, okay? And the age here is about 10 to 30 years old, okay? And females actually have a 1.8 times likelihood ratio of having an immune-mediated colitis compared to men. In terms of the timing, this is also one of the hallmarks that allows you to classify a immune-mediated colitis, okay? It's very insidious, all right? It takes place from weeks to months, and many times the patient will realize that they have this colitis only after having 4 to 6 bowel movements several weeks into the course of the disease. In terms of the risk factors, it's very not well studied. Common things being common, we're talking about things like anxiety and depression. That's a very common risk factors, okay? And also this being an autoimmune, this immune-mediated colitis, we're also thinking that autoimmune conditions will also be risk factors as well. So if a patient has, for instance, celiac disease or some thyroid problem, Hashimoto's thyroiditis, they're more likely to be predisposed to having another autoimmune condition such as Crohn's or ulcerative colitis. Okay, so in terms of the associated symptoms, this is actually another hallmark feature of immune-mediated colitis that allows you to separate it from the other types. You'll have many unique associated symptoms with Crohn's disease and ulcerative colitis, and these include things like skin rashes, okay, joint diseases, oral ulcers, vision changes suggestive of uveitis, and also weight loss. Okay, so very important, skin rash, arthritis, and also ulcers in the mouth. Those are very unlikely to present in the other types of colitis. And finally, diagnosis is really based on the biopsy. Okay, so in terms of the biopsy, all right, try to look around these two pictures and see if you can identify which is which. In one of my previous videos, I discussed that the hallmark of Crohn's disease on pathology and histology is that there will be non-caseating granulomas in the setting of transmural inflammation. Okay, so transmural inflammation means that there is a full thickness inflammation throughout the intestinal wall, and also you'll have non-caseating granulomas that are not suggestive of necrosis. Okay, so if we dissect this picture here, we see that this is the mucosa, okay, the muscularis mucosa, the submucosa, and also the muscularis propria right here. Okay, 4 layers of this, right? And we see that these little blue cells are neutrophils and lymphocytes, and we see that they kind of live their way and go through the entire thickness of the gut wall. So this is likely to be Crohn's disease. Okay, another feature right here, look at this, non-caseating granulomas. Okay, so this is very important. This tells you that this picture right here is Crohn's disease. In terms of ulcerative colitis, the hallmark of that is crypt abscesses, but this is obviously a not very high-powered field of magnification, so we can't really see them. However, what we can see is another interesting distinguishing feature in biopsy, and that is these little, look at this flask-like ulcers, okay? So ulcerative colitis is distinguished from Crohn's disease based on the fact that ulcerative colitis really only affects the mucosal layer. It doesn't really affect the inner layer. All of this is not really affected, right? And you will see ulcers that primarily affect the mucosal layer, and we see that this is a perfect example of that right here, and this is called a flask ulcer. So notice the shape of this ulcer. It looks like Erlenmeyer flask, and that's how it was named. So really, biopsy is the gold standard for the diagnosis of Crohn's and ulcerative colitis. So on to our third type of colitis. This is ischemic colitis, okay? So in terms of the demographics, we're really thinking that the elderly are more likely to be affected. So we're thinking that demographics age include older than 65 years old, okay? And there is no gender preference in this one. In terms of the timing is actually quite unique to ischemic colitis, but is also quite variable. So let's think about it like this. There's really 3 different phases of ischemic colitis. The first phase, okay, is a hyperacute phase. All right, this is where the patient has severe pain, okay? The next is a paralytic phase. In the paralytic phase, the pain becomes less severe, but it becomes more constant. And throughout all of this, the first two phases, the patient is losing quite a bit of blood, okay, in the stool. And the third is shock. So let's talk about why that relates to ischemic colitis. So ischemic colitis suggests that there is ischemia leading to potential infarction and necrosis of the colon wall, right? So it's not too hard to imagine that during the first two stages, stage 1 and stage 2, you have the loss of blood and also the ischemia leading to, possible infarction. Then the gut wall begins to slough off, okay? And it begins to become very porous, so that in the third stage, it's called the shock phase, okay? So in this phase, the patient can go into shock, okay, from losing too much fluids, okay, from fluid shifts because they're losing albumin, due to the porous nature of the gut wall at this point, okay? And that really brings the patient into a shock phase. But really, the timing is actually quite variable depending on the severity and the chronicity of the ischemic colitis specific to the patient. So it's not really, so we can't really use the timing to distinguish ischemic colitis from the other types of colitis usually. In terms of risk factors, this is very key, okay? So we're thinking, as I mentioned before, 65 and older, right? Ischemic colitis, so cardiovascular risk factors is really the key here, okay? So patients who have atherosclerosis, hypertension, type 2 diabetes, anything that is really a systemic arterial disease, that is likely to cause ischemic colitis. In addition, patients who have irritable bowel syndrome, constipation, and also hypercoagulability disorders. So for instance, if you see a woman in her 30s or 40s who has ischemic colitis and none of the risk factors, none of the cardiovascular risk factors, really you want to send this person to a hematology oncologist and really get a extensive workup for a coagulation disorder, okay? Or a hypercoagulability disorder, I should say. In terms of the associated symptoms, the patient is likely to have pain after eating, okay? So remember, this is ischemia, right? Ischemic colitis. So remember in cardiovascular diseases, we're talking about acute coronary syndrome. The patient begins having chest pains on exertion first, right? And that is called the typical exertional angina. And what happens is you have an increased demand, okay? But the supply remains the same. So you have the increased demand, okay? But the supply, I guess you can say it's unchanged, okay? And the same thing happens here. So the hallmark of the associated symptom is that the patient can get pain after eating. So soon after eating, right, the patient will be bringing the food into the gut wall, and the gut will be, utilizing ATP and energy to kind of peristalse, all right? And during that period of time, the gut becomes more active than it is at baseline. So you can think about it as the demand goes up, and if the demand of the gut wall goes up, you can imagine that the blood supply needs to go up to kind of feed that demand. However, if the supply is kind of compromised, it's not increasing to meet the demand, you're going to have pain, and that's the type of pain that is experienced as ischemic colitis pain, right? So these patients, the hallmark symptom is that they will have pain about an hour after eating or so, and usually is in the setting of a 65, 75-year-old man or woman with prominent cardiovascular risk factors. And finally, in terms of the diagnosis, okay, so it's really two parts. The diagnosis consists of a colonoscopy, but also of a biopsy as well. A biopsy is very important in differentiating an ischemic colitis from an indeterminate colitis, okay? So in terms of the colonoscopy, what you will see is, I remember this is the colon, okay, this can be a really bad picture, but here it goes. Okay, rectum right here, okay. This is the cecum area right here. Okay, so remember the blood supply is the SMA, okay? The SMA really feeds these areas, okay? And over here, there's this watershed area that's also fed by the IMA as well, okay? Oh, geez, excuse this poor picture. Oh, I gotta get a pen. So IMA is right here. Okay, SMA feeds part of this this area of the colon. This right here is called the splenic flexure. It's called a watershed area where the blood supply is tenuous, and it's also shared between two other arteries. Okay, so it's not too hard to imagine that this watershed area is likely to be poorly perfused. Okay, so on the colonoscopy, you will be you will be seeing a pale or dusky mucosa right about here in this watershed area that's suggestive of necrosis or infarction. Okay, if you take a biopsy of the mucosa of this area, right, so in terms of the biopsy for ischemic colitis, right, remember this comes back to this being an ischemic colitis versus another type of colitis. So what's the next step after ischemia is necrosis. And the hallmark of necrosis is cell death with loss of the nuclei, and we can see that very clearly here. These cells don't have any nuclei here, right? And also there will be edema, okay? And also, signs suggestive of distorted crypts, because these crypts are distorted because there's necrosis and this is sloughing off, okay? So very importantly, remember how in the heart you will have granulation tissue, 3 to 7 days after you have a myocardial infarction. The granulation tissue is really the revascularization of the area after an infarction, and we see that here as well. So look at this granulation tissue here, and we can also see the granulation tissue sprouting up, okay, here from underneath the basement layers as well. So this is the type of biopsy picture that you will get for a patient with ischemic colitis. All right, so now we're off to our final, the fourth colitis, and this is the microscopic colitis, the idiopathic, the fourth eye, okay? So in terms of the demographics, this is going to be also older than 65, okay, and also women more likely to be affected by men. The timing is actually quite acute in onset, okay, acute onset, and the patients will have diarrhea for 4 or more weeks. All right, in terms of the risk factors, it's similar to the autoimmune condition. Risk factors actually include autoimmune conditions such as rheumatoid arthritis, celiac disease, or thyroid diseases. So this is, quite similar to Crohn's or ulcerative colitis in terms of the risk factor stratification. In terms of the associated symptoms, this is where it's very important. So this is really the only type of colitis where you will be sure that the patient will have non-bloody diarrhea. Okay, all the other types are likely to have, potentially likely to have bloody diarrhea. Idiopathic microscopic colitis is the only one where the diarrhea is for certain to be non-bloody, and that's really the hallmark. Other hallmark features include nocturnal diarrhea, fecal urgency, and also fecal incontinence. So these are features that are not really shared by the other 3 types of colitis, and it's very important to remember because it will help you differentiate this one from the others. And finally, in terms of the diagnosis, okay, colonoscopy will be needed, but it's not too helpful in terms of finalizing the diagnosis. And let me tell you why. So think about this, microscopic colitis. So macroscopically, on colonoscopy, on gross examination, you will have really a normal picture. The colon will look normal. The gut wall will look very normal. If you take a slice, if you take a biopsy, okay, of that normal looking colon, the histology will really show several things depending on the subtype that we have. So there's the lymphocytic and collagenous types, the subtypes of the microscopic colitis, right? In both of these types, you will see that there will be surface flattening, okay? And that's one of the hallmark features that differentiates this type of microscopic colitis from the other types. And really, if this is the really only hallmark feature, of course, you will not see anything else macroscopically, right? So let's think about which one's which. So I'll just tell you. So this one's lymphocytic and this one's collagenous, not to make it too obvious. In terms of the lymphocytic, the criteria is that there needs to be greater than 20 lymphocytes per 100 epithelial cells. And certainly we see here there's so many lymphocytes, of course more than 20 per 100. And that is a differentiating factor for lymphocytic microscopic colitis. In terms of the collagenous colitis, once again, it has the surface flattening, okay, but also look at this area here. We see this collagenous subsurface collagen band, and that also helps you to distinguish that this is a microscopic colitis. All right, in summary, so we pretty much talked about the 4 major types of colitis. Okay, we went over an overview of what each one means, the pathogenesis for the most part, and also who's likely to be affected. I think the takeaway is really to have a very structured approach when dealing with colitis, right? The patient presents with a diarrhea, okay? So is it infectious? Is it immune mediated? Is it ischemic? Is it idiopathic? It's very important to be able to differentiate because, of course, for management purposes, each one of these will likely have a different management approach. And the way we think about colitis, as I try to kind of get through to you in this video, is to take a very structured approach, right? So remember this approach right here. let's talk about demographics, timing, risk factors, associated symptoms, and also diagnosis. So if you think about these 5 different factors here, using them in combination and in conjunction will really help you to distinguish one type of colitis from the other ones.